we have Dr. SANITHA SATHYAN. She's going to give a talk on approach to disc edema, a case-based discussion. Dr. SANITHA is a medical director of Vettam Eye Hospital, and she's a pediatric ophthalmologist. Over to SANITHA.
Thank you, Dr. Rehna. So I'll be talking about approach to disc edema. So first thing about disc edema is to differentiate between a true and a pseudo disc edema. Pseudo disc edema can occur in congenital anomalies, optic nerve drusen, Burgmeister's papillae, morning glory, sometimes may give a false impression of a true disc edema, myelinated nerve fibers, even hypermetropia and tilted disc, glial tissue proliferation over the disc, drag disc, dysplastic disc. All these conditions we might feel that there is a disc edema, but basically it's a clinical diagnosis. Of course, you can use some ancillary investigations to differentiate that too. So in a true disc edema, there will not be spontaneous venous pulsations. Retinal striae, engorged veins, retinal hemorrhages, fluorescent leakage, all are features of true disc edema. Enlarged blind spot may be seen in some optic nerve drusen as well. Examination of optic nerve or disc edema. First thing is visual acuity. Depending on visual acuity itself, we could suspect some diseases like an AON or optic neuritis or papillary edema. In AON, especially with the arthritic one, you have a more severe visual acuity loss, whereas papillary edema and optic neuritis may not present with that kind of a visual loss in the early stage. So pupils, RAPD in unilateral diseases involving optic nerve, it is very common to get a RAPD. Color vision is also a very important test when you talk about disc edema, because color vision may be grossly defective, or in some cases like optic neuritis, you can actually have a color desaturation. Contrast sensitivity is also affected. Visual fields, we have had a exhaustive discussion on that. And basic thing would be a disc appearance, which would help us to discern some causes as such, like optic neuritis or optic, AION. And spontaneous venous pulsations, we have already talked, and RNFL opacification also may be seen. The next thing would be to differentiate, it would help you to differentiate the diagnosis also, whether it is a unilateral disc edema or a bilateral. All unilateral cases may go into a bilateral one later. AON is the classical unilateral disc edema, neuroretinitis, optic neuritis, papillitis, papillophlebitis, retinal vein occlusion, ocular hypertony, Foster Kennedy. All this can present with unilateral disc edema. In bilateral cases, there could be compressive lesions, infiltrative lesions, diabetic, hypertensive papillopathies, systemic diseases like Graves causing bilateral disc edema. Cavernous sinus thrombosis, CCF, and LHON all can cause bilateral disc edemas. So this is a case where a 24-year-old female presented with headache and vision. Her only complaint was occasional headache. Visual acuity 6.6 in 6, color vision is normal. When you look at the disc, you can see there is hyperemia of the disc with blurring of margins. And investigations also, there is some enlargement of the blind spot on the perimetry. MRI, MRB was done to rule out cortical vein thrombosis, which turned out to be normal. And CSF study, we know this clinches the diagnosis with high opening pressure. It's a idiopathic intracranial hypertension. So you have a lot of people who are asymptomatic, especially young females who come accidentally to your OP for some other things, and they are diagnosed with idiopathic intracranial hypertension. And it can be, I think we ophthalmologists see them first, and diagnosis is very critical because it actually gets cured over with use of proper medications. And case 2 is a 40-year-old female who presented with sudden painless defective vision of 1 week duration. She was actually diagnosed case of mixed connective tissue disorders, and the vision in left eye was hand movements. That is a much higher visual loss, and left eye had an RAPD. This is the fundus photo. You can see the disc edema in the left eye. and also in the OCT and in the FFA, where you can, in the late stages, there is a disc leakage also. And VP also, there was a change. So this is a left arthritic, non-arthritic ischemic optic neuropathy. In case 3, this is a 38-year-old male with sudden defective vision. So he had painful eye movements. This is a very typical feature of optic neuritis. And the vision was 636 in the right eye with grade 3 RAPD. And color vision was also impaired. BP was normal, and he had a optic nerve thickening in the MRI. So this is a right eye optic neuritis. Optic neuritis can have many causes, and depending on that, most of them systemic causes are also. So you can have a classification of demyelinating, infectious, para-infectious, and others. So in the demyelinating group, we have the most common one, most important one, multiple sclerosis, usually in young adults. And sometimes they might present, usually I think 15 to 20%, the first symptom may be a optic neuritis of multiple sclerosis, and most of the patients, like 50% of multiple sclerosis patients, they might have a episode of optic neuritis somewhere in the course of the disease. And then neuromyelitis optica and other Schilder's disease, encephalitis periaxialis concentrica, all these are demyelinating causes. Lately now new antibodies are also being investigated, and especially in Devick's disease, NMO-associated optic neuritis. And infectious and para-infectious causes, virus, adenovirus, Coxsackie, measles, mumps, rubella, varicella, all this can produce optic neuritis. And also bacterial causes, tuberculosis, syphilis, Lyme's, cat scratch, streptococci, all this can actually cause optic neuritis. People do come with post-vaccination optic neuritis. Diagnosis is a bit tricky, but the cases are reported in this. Inflammation, sarcoidosis is an important cause, and many other causes like Guillain-Barré, birdshot, retinochoroidopathy, toxoplasma, toxocara, all can present with optic neuritis. So now let's go to cases of bilateral disc edema. So this is a typical papilledema, and the disc edema is much pronounced. So causes can be, one, due to cerebral edema. The classical one we see in a cortical vein thrombosis, idiopathic intracranial hypertension, or hydrocephalus. The second classification would be a compressive optic neuropathy, in which the compression can happen at any level of the optic disc, optic nerve, intraorbital, intracanalicular, optic chiasmal, or even in the optic tracts. So you can have optic nerve sheath meningiomas, thyroid associated orbitopathy, idiopathic orbital inflammatory syndrome, and suprasellar tumors, classical one being pituitary adenoma, craniopharyngiomas, aneurysms of internal carotid and ophthalmic arteries, anterior communicating arteries, sphenoid sinus, mucocils, and fibrous dysplasias involving the sphenoid bone. All this can cause compressive optic neuropathy. Another group would be a infiltrative optic neuropathy. These cases do come to our OP, and sometimes it may be the first ever presenting symptom of a leukemia or a lymphoma. I had a case recently. So primary tumors can present, primary tumors of the optic nerve, like an optic nerve glioma associated with NF1 and ganglionomas, and secondary tumors like lymphoma, leukemia, leptomeningeal metastasis, inflammations like sarcoidosis, infections, tuberculosis, toxoid, crypto, all this can present with infiltrative optic neuropathy. One last word about toxic optic neuropathy. Usually we all see these cases in the post disc edema stage with pallor, but in acute stage actually they can present with disc edema as well. All this chloramphenicol, ciprofloxacin, linezolid, sulfonamide antibiotics have a potential to develop toxic optic neuropathy. So as anti-malarials, ATT drugs, chemotherapeutic agents, even antiarrhythmics, antiepileptics, and even in methanol poisoning we have seen such cases, and heavy metals and carbon monoxide tobacco, all this can produce toxic optic neuropathy. So this was a nutshell about disc edema. Thank you for your patient listening.
Thank you, Dr. Sanitha, for that very nice talk.